It's clear and
Absolutely.
nice.
Yes, yes,
Okay.
absolutely fine.
So now, as per, you see, I always follow rules, and Suman and Shwetal told me half an hour, it's 8:15, so I'm taking off. So, and
Sir,
also,
take your
I,
time.
also I would like to, because I can't see myself, I'm just seeing the screen. Can you see my small snippet, my face and some actions which I would be doing? Can you see that?
Yes, sir. Yes, sir.
Okay, okay, thank you. That's great. So, good evening, friends. So, firstly, I'll just give you a brief structure of what I'll be talking about because, as Madam had said, that books have been written and 2 day workshops are there. But in this half an hour, I'll try to sensitize you and give you an idea what the whole thing is. So, I will be speaking basically on the subsequent format. Number one, we have to sensitize ourselves to preterm birth, which is a global burden. It's a global burden. And also, along with that, we will have to discuss and realize about the increased survival of the micropreemies and extremely low birth weight babies. But the concern is the neurodevelopmental outcome. Second thing, I'll just touch upon the intrauterine and the extrauterine environment vis-a-vis the positive and the negative sensory inputs on the fetal brain as well as the preterm brain. And we'll talk about core measures, which are the main core measures which lay the foundation of DSC. And in that, I'll be discussing about therapeutic, few of them because all is not possible. Therapeutic positioning, which is a very practical issue. I'll tell you about stress and self-regulation and sleep states. And also I'll touch upon the new thing which we have been doing for last some years, octopus therapy. And in the end, I will show you a few videos. And with the videos, you'll be able to get a better grasp of the situation. So this is the place which I come from. That is Paras Hospital, which is a tertiary hospital, and we have a tertiary neonatal unit there. I had a good opportunity. Dr. Suman had also come there when we did a ventilation workshop, if you remember, during Neocon. And so DSC Foundation is also the base here. Is the core center of DSC Foundation is Paras, where we have been working on this research for the last 10 years, as Dr. Suman had mentioned. Now, at the outset, I would like to just tell you, and we all know that the last 3 to 4 decades, 30 to 40 years, we have had huge advances, you see, in knowledge base, one, and technical advances, technology in antenatal, perinatal, as well as neonatal care and sciences. This has improved the survival of the tiny micro babies who are below 1,000 grams or below 800 grams to hell of an extent in all big units across the world, and in India also all tertiary units are saving. But however, you have to keep in mind, so when we have a big preterm global burden, second, they are surviving, so there's a huge pool of small babies. But the matter of concern is that the the incidence and the morbidity of neurodevelopmental impairment in this population has really not gone down. So it is a matter of deep worry, and we should all really work hard as neonatal caregivers together to achieve good functional outcome, good neurodevelopmental outcome, and the golden slogan of ours is intact survival, so that these tiny babies can grow up into healthy infants, healthy children, adolescents, and adults, and be productive for themselves and for the country. Now, as you know, that it is now increasingly clear that even 24, 25, 26 weaker babies are surviving. And also, that there is a huge influence of the environment on them. They respond and react to them. That is it. And now, if you try to understand preterm birth, what does it do? Preterm birth brings the baby out much. See now, just to revise, below 28 weeks is extremely preterm. 28 to 32 weeks is very preterm. 32 to 34 weeks is moderate preterm. 34 to 36.6 days is late preterm and then term. And we have 1500 and below low birth weight. 2500 and below is low birth weight. 1500 and below is very low birth weight. 1000 and below is extremely low birth weight. And 800 and below is incredibly low birth weight. Now, these tiny babies, once born preterm, are forced to continue their critical neurological growth extrauterine. So this is this whole scenario which we have to look at. And as you can see, the advances which you have must seen the slide by now, better understanding of function, respiratory devices. I won't waste time on that. Just a look at preterm global burden. Born Too Soon was a project in 2012, WHO. They said this is the first time that we tried to find out how many preterms are happening the world over. So as you can see, the Western world or developing world, let us say, and the developed world is all the same. As you can see, I'll put my cursor. India, the figures they had was leading with 3.5 million births. Russia had 1.1 million. Even America has 0.5 million. So, this is a global problem. And everywhere the babies are surviving due to advanced sciences. So, having said this, now we will get into the meat of the subject. Here, I would like you all to remember not many milestones, but at least two important milestones intrauterine. Quickly to say, number one, the last trimester, 7, 8, 9 months, we have the fetus developing a flexure tone, as I am showing you there, in midline orientation, which happens in the last trimester. Before that, the baby is in extension because the back muscles are developing. And 7, 8, 9 months, the ventral muscles are developing, so the baby comes into contraction. The baby is becoming larger in size in the uterine wall. This development of the flexure tone and posture is most important and is the foundation for future neuromotor development and also neurobehavior. Please remember this midline orientation flexion, how important it is. Now see, here you have a 26 to 28 weeker who is low tone and is in extension and is lying flat like I'm showing you. And the gravitational pull, if you can understand, is pulling the baby down. And so now you have a tiny baby. He's a 1200 grammer, 1000 grammer, HMD. Everybody says, unit says, sir, impending delivery, fine. So there was distress. So we have put him on CPAP, but now I think we need to give him surfactant. So you do that, and then you do insure, intubation, surfactant, extubation, and do all those things, and you're better. You put in a UVC line, and you put in trophic feeds, etc., everything. But what about the position? So these babies they stay with you for weeks, months, and if you leave the baby in this position, what is going to be the outcome? You can yourself from the picture understand. That is what we'll be talking about, therapeutic positioning. This is the more comfortable baby who is absolutely fit and fine and is in a flexed position. The next thing is, I'll be a bit fast. The next milestone which I'll talk about is third trimester is the brain. The brain is very busy. As you know, you have the germinal matrix, which is the factory which produces neurons and glial cells, and all the maturation is happening. At this time, the brain is really active. There's production of cells which are maturing. And as you can see, my two hands, there are two neurons which are being formed. Then there is a synapse between the two. And so there are in a newborn, 100 billion neurons finally compose it. The figure is staggering. And they are being made, the factory is churning them out at the rate of 250,000 per minute. That is the huge activity of the brain, of the germinal matrix. And then they are maturing and spreading, migrating to the various portions of the brain. But you can see there are so many neurons and so many joints, synapses, there is also pruning. जैसे कि, I will break it to a bit of Hindi. अभी बारिश जब होता है, when it rains, the grass grows in a very haywire manner and you have a jungle. Your person or gardener has to trim the whole thing and make it look nice. Similarly, there is pruning of the synapses. Extra synapses are thrown out. They are pruned. The brain cells mature and reach the. So this is a very active moment, the last trimester. So you can understand at this time, if you give negative sensory input, what is going to happen. So this is what I would like you to be very clear on this. The third trimester is a very sensitive time. And if you're born preterm at 27 weeks, you're going to give what kind of sensory input we will see subsequently. Quickly, intrauterine environment is absolutely perfect, conducive, positive sensory input. I will go further ahead. You see this baby who is here, who is floating in their fluid, is in midline orientation, is in containment with flexion, one. Number two, less exposure to sound and light. Number three, a constant connection to the mother through the somatosensory and auditory pathways. And finally, most importantly, preservation of the sleep cycle, which helps the baby to grow. This is the list. I will not bother you to read this because I will explain in the picture. Now remember the uterine wall, uterus considers like a boundary. Then vestibular, you see maternal fetal movements. There's vestibular movement, vestibular stimuli also. In the day, when the mother is moving, the baby is having a nice rocking situation and the baby goes to sleep. In the night, when the mother sleeps, the baby starts kicking because the rocking is gone. Talk about the auditory interesting part. Maternal voice and heart sounds the baby can hear. Remember that. And the blood flow through the placenta. And most important is the filtered sounds. Filtered sounds from extrauterine environment which pass on to the baby or through the skin, through the fatty tissue, through the muscle, through the organs. So it's a natural filter created by God where the sound is in a very soft. My huge big voice where I am speaking so loudly will reach in a very controlled decibel. Now, in the NICU, what is happening? You have the fancy incubators, babies are all alone, and that is job-oriented work going on. Everybody is busy trying to dedicatedly take care of the baby. But here, please remember, we have to consider that baby is also a person. We have to talk to the baby, look after the baby, and have interconnection with the baby and also with the family, which we will talk about subsequently. What happens? Boom. As the baby is born, temperature, tactile, touch, everything goes haywire. Olfaction, gustatory, sound, light. In short, and then the array of painful procedures, which everybody knows, intubating, peripheral cannulation or PICC lines, and so many things. In short, the positive sensory input which the baby was getting in intrauterine is changed into negative sensory inputs because of our methods. If we are not humane, if we forget this part and concentrate just on the therapy, we would miss out. Negative sensory inputs replace positive sensory inputs, which can permanently alter brain. So this is the most important issue. You see this tiny baby on the right, the picture, absolutely in the best of technical advances. Everybody else, you can see all over, they are concentrating on therapy. But the baby is in a horrendous situation. So we have to look after to reduce the stress as much as possible, as you can see over here. Now, it is control. It is nowadays, it is not only controlling the stress, but we have to look into many other points, which I'll tell you in the now. What happens? A preterm baby is highly labile, saturation up, down, heart rate up, down, and you will add on oxygen or sedate or whatever. But it is all unnecessary because it is naturally autonomic instability in a very, very preterm baby. This is stabilized by DSC. Neurobehaviors are improved, which I will talk about. What is neurobehavior? Sensory, motor, and neurological, and of course, the weight gain, feeding, and so many things, they are improved. Now, who does it? Uh, we can't, the one person cannot do it. Um, um, Even in our unit, I am useless on my own. It is a whole team. The babies in the center. You have to have the neonatal caregivers, which includes the neonatologist, the pediatrician, the NICU sisters, or the fairy godmothers who understand the baby moment to moment, the family, and neonatal therapists. And abroad, there are certain units who are having neonatal neurologists also. It's not only the test. So we have to work out in a team. Now, quickly, I will rush on to the core measures. Earlier, there has to be 5 core measures, which lay the foundation of a unit who wishes to become accredited as a DSC friendly unit. These are disease independent and promote healthy growth. So just concentrate slowly on these 5. Number 1, most important, is protected sleep. Deep physiological sleep, which gives you maximum brain growth and weight gain. That's what you want. Assessment and management of pain and stress. And please concentrate on the third one. It used to be called developmental activities of daily living, where the main job was baby's positioning, feeding, and skincare. And of course, family centered care and the healing environment, which I will explain. So these are 5 sensory experience. But now, in 213, now that was in 209, and we used to follow that. Today is 2024. So around, it's been 10 years. So around 2014 or so, we started our work on this subject. And 13, we did 1 year of literature review. Then we made formats, then we made some educational modules, and then we started learning, self-learning, and we are still learning. So subsequently, the 5 core measures were altered into 7. Altimer is the person who did it, and I had the good opportunity to interact with her because there's a book, if you, I mean, which I'm sure you must have. It's a very wonderful book brought out by IAP and NF, the clinical neonatology textbook, big fan. So we had the opportunity to write a chapter there. So the iPad has been remodified by us, and for that, I had connected with her to say that I'm changing and adding a few things. She was very happy, and so we have shared. It is there in the textbook. So what are the 7 things which she did? Now, you see, if you see this list, the third one of activities of daily living, they had 3 subdivisions, but now positioning and handling has been given a separate entity. It is very important therapeutic positioning. Protecting skin at number 6 has also been given a separate issue. And just feeding was a very mundane theoretical situation. Now it's become very clinical, optimizing nutrition and feeding, which is a huge big chapter on its own. So please remember a lotus. You see, healing environment is one, the sensory systems, the five ones with vestibular in addition, partnering with families, positioning and handling. Then the fourth is safeguarding sleep. Protection sleep has been named as safeguarding sleep. Stress and pain, one word here because I can't talk about all the core measures, but earlier it was said that the babies, infants, and newborns cannot do not experience pain, and they cannot sort of have a measurable response. No. Research has proved, we all know very well, that acute pain exposure can disturb the autonomic stability in a huge way, and repeated exposure to pain can give you problems in neurodevelopmental outcome. Hence, any evidence-based work protocol should have a pain protocol in your unit, whether you use premature infant pain profile, facial coding scheme, or whatever, something has to be there to monitor pain in your unit. Now, for example, I mean, I don't have the participants with me, but otherwise we would ask that, tiny baby, how many painful procedures does a 1200 gram average go through a day? Well, I'll tell you, you see, anything between 5 to 15, an average of 10 to 12 per day. And how? Because even putting an OG tube is an extremely painful thing. Adhesive tape removal is very painful. Intubation is most painful. While you're ventilating, you are in tremendous pain, the tube procedure. You have diagnostic where you can heal peripheral cannulas, PICC lines, and so many things. And therapeutic, even OG feed or adhesives, intubation, so many things. So we have to see that we have some pain protocols to monitor as well as pain reduction modules, pharmacological and non-pharmacological, wherever required. Skin protection, optimizing nutrition. I'll just say one word, that please remember that the best thing for these tiny babies is dedicated human milk diet. We follow it very strictly in our unit, that nothing other than the mother's own milk, MOM, or pasteurized human donor milk, which is PHDM, enters the baby. And breast milk banks are now coming up. In our unit, we try to use a combo of both, ABMN on that. And that has great positivities, which I will not elaborate on. You all know it. And another point I would say that when there is an impending delivery, you have to counsel the mother and the family that as the preterm baby is born, you have to ask the mother and tell the mother and convince her that she has to express the breast milk at least 6 to 8 times in a day. Then only will you get an adequate flow of milk within a week, so that the mother's own milk replaces the pasteurized. And of course, you should start as possible a bit forcefully on the enteral feeds, even up to 20 ml per kg, as our experts, Dr. Suman, Suital, everybody is here, Kedar is here. All our units start on human milk at a larger volume per kg as the trophic feeds. Now, this is the same thing which we have talked about. As you can see, there is a healing environment in the center, and partnering and all the other things have been set aside, and vestibular in the center. And now just one word, very important for all of you to take home, is the sequence of maturation of the 5 sensory systems. Vestibular comes in between. If you stimulate your baby, out of turn from the maturation point of view, the baby is going to be in problem. So touch, smell, taste, hearing. I will show you a method how you will remember this, the sequence, otherwise impossible to mug up. You touch somebody, you embrace somebody, you shake your hands. So touch, as you can see me, is first. Then you come down, then comes olfactory, nose. Follow me, please, on the picture if you can see me. Then you come to gustatory, taste. Then you go clockwise. You go to auditory. Then you come to visual. In between, you fix vestibular. So this is the sequence in which the maturation happens. The first sensory system you can stimulate is tactile, then is smell, then is so on. So sound and light right at the end. So this is the picture as you can see. I'll rush, time is running short. And protected sleep, I have already told you, safeguarding sleep. I will not waste your time because time is short. Non-emergent jobs to be done in wakeful state, and caregiving activities must have facilitated tucks, fondling, the pharmacology, non-pharmacological methods, skin to skin, KMC is a must. It's a very major thing. And we have Dr. Suman, who is one of the pioneers and the experts in this. And definitely that gives you all the vestibular help, tactile help, everything, light, sound, and families partnering. Stress and self-regulation, quickly I have to tell you, is these are two things you must know and try to recognize. Time is short, but this is a format which we did research and found out, and which we are using and we are sharing with people. Now, if you just remember how to remember all this, if you take your left hand and take it as stress, you have three types of stress: autonomic, motor, and attention. And on the right side is self-regulation, which is a calming of the baby, which is good for the baby and the best for the baby. And then in the center, you have the sleep behavior, sleep states. So having said this, I will quickly shift. And so this is one line, autonomic. You know all that, but you have to record it, the autonomic. And here, if you see the thing, the format which later on we can share by some method, by connecting with Dr. Suman and Dr. Shwetal, you have the positioning of the baby, you have the oxygenation of the baby, whether he's on room air, nasal cannula, CPAP, NIPPV, or ventilation, and feeding status. So this huge thing is filled up only when major changes are there in the baby. And as your preterm is progressing, you will see the stress is decreasing and the self-regulation is increasing. That means your baby is on the way up. Pictures of stress, autonomic stress, everybody knows about. Motor stress, you see, back arching, playing. This is a very, we have been studying these stress signs, self-regulatory signs over the last 10 years, and we learned and taken videos, and we have a library. So that is how you will also from tomorrow onwards look for these things if you stay with your baby. And then these are the pictures which I'm showing you. Time is running short. And then autonomic, motor, and attention, where there is, hyper alert or gaze aversion. Self-regulation is the best what we want for the baby. The number one self-regulator is flexion in midline orientation. As soon as you enter your unit, you should first have a scan of how the babies are lying, tiny, ventilated, or whoever. Flexion, hands to face, hands to mouth. And this, by the way, the neonatal caregiver will be putting hands to face because a 28-weeker cannot do it himself or herself. So we have to self-regulate the baby. Please observe this dialogue. We have to self-regulate the baby. This is nesting, as you can see, and then bracing, pushing it. And this is, the other one is grasping. A very interesting thing. Small little finger can be given to the baby, mother's little finger, sister's little finger, neonatal caregiver's little finger, grasping. There will be good self-regulation and calming. Here he's holding on this. This is a very stressed out baby, as you can see. Positioning, I'll rush through. And time is short, I cannot explain, but this is again the modified infant position assessment tool, which was by Altimer and Philips Children's Medical Venture. But in 2020 and earlier, you see now there are 1, 2, 3, 4, 5, 6. How do you remember? It was all haphazard. So we sequenced it. First comes your head. You can all see me. Then comes the neck. Then come the shoulders. Then comes the hands and arms. Then the hip and the knees and ankle. So remember this way. If your head is more than 45, you get 0. If it is at 45, you get 1. If it is midline and less than 45, you get 2. Neck, hyperextension, hyperflexion and hyperextension is bad, you know it. It has to be semi-flexed in neutral position, airway in line. Shoulders, if retracted as I am showing you, you would get a 0. Just see, if you all do it along with me, it is quite stressful to remain like this. If you make it neutral, you get 1, and if you are rounded, you get 2. And hands away from the body, you will often see preterms lying with hands away, is 0. Touching the torso, 1, and hands touching the face and in midline and flexed, we get 2. Hips, frog-like position is bad. It should be aligned, softly flexed, and knees and ankle. Here what we have added is, we have added the autonomic also. As you can see, heart rate, respiratory rate was not in the original. And now we are going to add sleep state also. And these are columns for recording in morning, evening, and night. So basically, you can get 6. There are 6 patterns. The 6 twos are 12 out of 12 or 0. 10 out of 12 is okay. Anything above 9 is okay. Below 8, you need to correct your position. This is a good objective way of looking at your baby. These are some babies from Paris, as you can see. Self-regulation, hands to face, nesting. This is a nice nest which has been made. There is an adequate trough, and the baby is well aligned. The diaper is a bit big, which is, diaper should be adequate. So correct frame. Nesting, maintain flexion, midline orientation, and this causes good self-regulation and protected sleep, and deep sleep causes a weight gain and brain growth. Here you can see this baby has got 10 out of 12 because he has got 2 and the shoulders are rounded, neck is straight, he has got 2, and then his hands to face and midline. Here he's lost a few numbers on his hip. He has got 10 to 12, 10 by 12. So you can record as far as going twice in each shift, and the scores I mentioned. These are few of our babies in supine position in our NICU at Paris with the nest, by the way, can be full nest, or it could be a caudal nest when you're ventilating a baby, or it could be a cephalic nest when you have got thoracic tubes or something. Supine position, prone position. Prone position, remember, is very good for breathing, everybody knows, and there should be position change on a regular interval. But prone position, please remember, should be always supervised, whether in the NICU, nursery, or at home, because it can lead to SIDS. Remember that. Everybody knows that. I'm just reiterating the simple thing. Sideline. Sideline also you should be nested. Remember, sideline position unsupported is the most stressful. There are graphs to prove that, but I'm just passing on the situation. While in the incubator, as you can see in our unit, still the same format of good therapeutic positioning has to continue. Sound and light methods have to continue. And sleep states, I'll quickly, because I'm running short of time, I've already crossed 35 minutes. I think Dr. Suman and Shweta will start sort of admonishing me soon. So now, quickly, sleep states are 6 in category. As you can see, deep sleep is deep physiological sleep. There is no movement of eyeballs below the lid. In light sleep, you will have movement of eyeballs below the lid, and there may be flickering motor activity. Dosing is twilight zone. awake can be quiet awake and wide awake. Quiet awake is baby is alert, looking around, minimal movement. Wide awake is activity, and crying everybody knows. Preterm sleeps longer, they can sleep to 22 hours, whereas terms can sleep up to 8. And here, one thing important about the sleep pattern, which I would like to tell you, is there is a thing called, everybody knows, rapid eye movement sleep. Now, we adults spend about 25% of the time in REM sleep. Term babies 50% in REM sleep, and preterm babies have 75% is REM sleep. Remember that. REM sleep is good for the stimulating the brain regions used in learning. So this is one point which I wanted to add as far as REM. And preterm sleep 22 hours and term babies sleep maybe up to 16, 17, 18 hours. And they have a haphazard pattern. The preterm baby, the sleep starts maturing as the baby becomes term. Now here, can you all see, Suman, can you see the video moving?
Yes, sir.
Friends, this is deep sleep where there was no movement. It's the baby quiet, no movement on the eyelid. Okay. So this goes zoom number 1. Then, now this friend of ours, you can all see slight mouthing movements, movement of eyeball below the lid. Breathing is more or less tolerable. And then if you keep a close watch, you will see that there is a small flicker. So this baby is in light sleep. So now one will say, babies in light sleep, do you intervene? No. If his autonomic parameters are okay and he's in light sleep, we don't disturb him. But however, these mouthing movements, you have to be sure that they are routine and not subtle seizures, and the flickers also. You have to be concentrating on the pathological process if there be any. This baby, as you can see, is in a drowsy. He's in twilight zone. So he's anyway quite cool and happy. Now, this is a friend of ours in our unit who is a quiet alert. His state of arousal is the other name. He's quite alert. He's giving a small smile, and his breathing is routine, and motor activity is less. If there was a good motor activity, you would say quiet alert would change into active alert. Now, sound light, I cannot go into details, but basically you can read up on the books. 45 to 50 decibels. We have sound meters, we have light meters, and Dr. Suman and the unit have made wonderful work on sound and lots of research papers. We have been also doing the same, but that is the thing which you have to start using, and you have to have a change of culture in your unit. Everybody has to understand, like we know what is that baby looks like 1200 grams or 1800 grams, but you have must know what is decibels and how much sound. Like I am speaking maybe at about 70 decibels. Similarly, lux up to 600 lux is permissible at the infant bed. These are at the infant beds. So this is a thing which I have got out from our unit. You can innovate things in your unit. Please don't copy this because this is on our entrance. And of course, neuroprotective interventions you have already gone through. Just a few to tell you: tactile, soft, gentle touch, no tapping of the baby, skin to skin care. Ultimate humidity is essential to 75-80% for the tiny babies. Vestibular change, olfaction, maintain a scent free, no aftershave, no lovely perfumes allowed to be worn in the unit. Mother's scent. Octopus is also a method which I will just quickly rush through. Gustatory, a drop of milk, express breast milk on the baby, even if there is no suck, swallow, and breathe. Even at 27 weeks is good. Auditory, visual, all these things we have talked about. I'll just rush through, if I can be given just 5 minutes, on octopus therapy, which is a very nice, innovative stuff. When in 2018, we were in uh, St. Petersburg, much before COVID, where the World Cup was held. We had gone there, we were invited, were happy enough to run a program of 2 days on a workshop on DSC and neuroprotection. And then we realized that something like octopus therapy is going on, and we were excited. So we were there for a few days. So we entered the unit after the workshop. We saw the whole scenario and brought it back to our country, and we have been sharing it. But now, of late, we have been able to arrange somebody who is making these octopi, which we would be happy to share, where you can get these. So here, it started in Denmark. 2003, there was a project. There's a community used to make this. This is, by the way, cotton, not wool. This is cotton. And I'll tell you in the subsequent slide how it is to be made. Now, what is happening? Why not a doll? Because these octopus who are there in the sea, if you make them, as the pictures I will show you from my unit, they have tentacles. They mimic the umbilical cord. And once the baby has the grasp reflex, which I told you is a very great self-regulator, they feel so happy that they are with mummy in the utero, and they are having this gripping tentacles. And also there's a chemosensory stimulation, which we'll talk about. Squeezing the tentacles creates a sense of safety. It settles your heart rate, and saturations are better. And also pulling of things, or pulling your tubes out and cannulas out, is not there. Now here, we at the DSC Foundation did a lot of work on this after we came back, and added something to what they taught us. They just taught us, they showed us that in this St. Petersburg, as well as Finland, Denmark, and Scandinavia, they put the octopus next to the baby. But we thought we would like to do some form of KMC. And we worked and worked on that. Octopus is first, if there is an impending delivery, the family is counseled with the slides explained of the matter, so that they become a part and they are team members of this program. The octopus is put in contact with the mother's skin in a manner similar to skin. Maternal body odor is transferred to the octopus. Then the octopus is placed next to the preemie, and the neonatate is stimulated by the maternal smell. This is called chemosensory stimulation. Neonate also holds the tentacles, reminding the umbilical cord, gets a whiff of the mother's scent, and we are mimicking comfort and safety of the womb. So this is one of our mothers. So now we have termed it, and we are going to, and we are having it trademarked. Octopus, we have now named it Octopus Mother Care. So you can, apart from being trademarked, you can all use it. Octopus Mother Care. Why? Firstly, the baby octopus is being given mother care because, as you can see, the baby mother is giving kangaroo mother care to the baby, as well as the octopus is there because she can save time, and both are getting skin to skin. Octopus to skin, and otherwise baby is skin to skin. Mother is quite happy, as you can see in our NICU. So the octopus is getting mother care. Then the octopus is taking over the responsibility and the work of the mother and lying next to the baby, and the baby is feeling mother is here. So it's the whole combo of octopus mother care. This is another of our mothers who is giving, as you can see on the cursor, octopus is here and here is her baby. And we have these chairs where they do KMC anyways. And this is another of our mothers who is very proudly exhibiting the octopus. And this is our other friend. And this baby, you can see, is having a grasp reflex, lying on the bed, is in deep sleep, and is very comfortable. We have found a good autonomic stability and saturation levels with this. With some work we are doing on this, and we are trying to create a paper out of it. This is a quiet alert baby. And this is another one. And this is from St. Petersburg, from our friends. And so this is also their babies, not ours. The earlier one. So now the new terminology which we have coined at the foundation is octopus mother care rather than therapy, OMC. And finally to end up, the whole story is about good functional outcome, good neurodevelopmental outcome, and intact survival. Before I read the final lines, neurobehaviors we were talking about, there are 5 neurobehaviors. One is stress, autonomic neurobehavior. Autonomic stress neurobehavior is one. Motor stress neurobehavior is 2. And attention stress behavior. So neurobehaviors are in 5 systems. 3 of this, self-regulation is another 4th one, and the 5th one is sleep. So these are 5 neurobehaviors. Remember, the last one to mature in utero is self-regulation. And the capacity of self-regulation is called neurobehavioral capacity. More term, good self-regulation. Fine, stable baby. Very preterm, less self-regulation. Finally, environment should not have sensory stimulation, more sensory stimulation than the threshold. There should be balance between the two. The goal is to promote a stable, well-organized baby who conserves energy for growth and development. No instability due to other reasons, states of arousal, not sleeping, pain, vulnerability to pain. Anand has done lots of work on this, disorganized behavior. So, improving functional outcomes, neurodevelopmental or intact survival. That's the final story. And so that's it. And so, Suman, I have finished 45 minutes of yours. So I think we don't have time for videos. I think we should maybe I'll stop sharing. And so that's it. So Suman and Dr.
Yes,
Shweta,
sir. Yes, sir.
I hope that was loud and clear. So I think the
Yes.
videos, we will leave it later on if we have time, because I have eaten up 45 minutes. I tried to be as fast as possible. And I think
Yes, sir.
that would be
Yes,
the
sir.
situation.
Excellent presentation, sir. It was really a great overview. And definitely we should attend your developmentally supportive care workshop for 2 days to go into the depth of this therapy. Thank you so much. Now, like in the different NICU, people are doing in their own way, but how to do the quality improvement? For that, we can invite, I would like to invite Dr. Kedar, sir, to share his presentation and experience.
Thank you. Thank you very much for inviting me. And that was a really wonderful overview of the developmentally supportive care in NICU. So I'll share my screen now. I hope the screen is visible.
Yes, sir. Just make it full screen, sir.
I have made it. Are you able to?
Yes, now it's visible, sir.
Yeah. Okay. Thank you. Thank you very much. So friends, today we have learned about what is developmentally supportive care and what are the core measures of developmentally supportive care. And we do learn in classrooms, in workshops, in conferences regarding many such topics. But when it comes to implementing those practices, we find it very difficult at times. And today, I'm not going to discuss you the methodology in detail, but I'm going to discuss the methodology, how we use it by an example that is developmentally supportive care in NICU. So using that example, we will just see how we can use it. And this is a very simple and basic example of implementation of a DSC intervention. So we all know, we have learned this subject matter knowledge in our classrooms and conferences, workshops, seminars, everywhere. We learn that, and that is very basic things. That is the professional knowledge. But there is also another kind of knowledge which is called the knowledge of science of improvement. And that is also essential if we want to implement those practices that we learn in day to day. This science of improvement is nothing but it's an interplay of theories of systems, the variations, the knowledge, and the psychology. Meaning thereby is we all have some theories that if we do this, if we give this, suppose medicine to a patient, it will result in certain outcomes. So that's a theory. And we all know there are many variations in our practices of, say, any processes or management protocols. It varies from unit to unit, even within the unit also, it varies from person to person. And we need to have some knowledge about or some methodology where we can implement or where we can improve the outcomes or the practices. And obviously, when it comes to implementation, you will all agree that the biggest barrier to implementation is the change in behavior of all the stakeholders, be it doctors, nurses, patients, or anybody involved in healthcare delivery. So we need to combine this subject matter knowledge and the science of improvement knowledge if we want to implement and improve our practices. This is a systematic review from a Lancet journal 2018 regarding the interventions to improve the healthcare worker performance. As you can see from this review, that the impact of training alone is just about 10% in implementation and improvements of any thing which we learn in our classrooms or seminars. We also resort to sometimes supervision. But on-site supervision is only giving us the impact factor of about 14.8. So if you combine the training and supervision, the total impact is around 18%. But if we have some methodology for implementation and improvement, along with our training, the impact is 56%. And friends, if we continue to do only training for years together, there is a famous quote of Albert Einstein. Doing same thing over and over again and expecting different results is a sign of insanity. We can't improve, we can't implement. And that is everybody's experience, universal, everywhere, in every context. And our knowledge of science is really improving very, very fast. The knowledge of level 1 interventions is very, very improving very fast. But the application of knowledge for the benefit of the end user is lagging behind. And there is this big gap between what we know and what we do. And this gap is widening day by day until unless we are finding some ways to implement our research. And while implementing or improving, if we straight away jump to solutions, we'll end up in problem because we'll miss all of this, the sense making, the stakeholder engagement. We don't have data, then we don't have a root cause analysis. We cannot understand the problem appropriately. And we will not understand because there are many biases in everybody's actually thinking process that a particular thing will work or will not work. So all these things we will miss and we won't be able to either implement it altogether, or even if we are able to implement it, we won't be able to sustain the changes for long. And therefore, we need some framework to implement or to improve any interventions in any healthcare field for that matter. There are many frameworks. You must have heard about Lean, Six Sigma, Model for Improvement, Total Quality Management, audit, everything. One such simple intervention is the point of care quality improvement, where there are 4 simple steps of identifying the problem and forming a team and writing a name statement. You all know that healthcare is a team phenomenon. So this team is the very most important aspect of any implementation or improvement. We must analyze and measure the problem and then find out some change ideas which are likely to improve the outcomes we are intending or the processes we are trying to improve, and test them on a smaller scale so as to understand whether it is working in our context or is it causing any harm, and then implement them. Sustaining those improvements is another big challenge. So these are the 4 simple steps we carry out in order to improve or implement any intervention. We do these quality improvement projects because there are a lot of benefits. We can identify the best practices. We can bring about lasting improvements. We need to standardize the processes to our context and reduce the variations in the implementing them. Also, quality improvement projects leads to increase in employee satisfaction and teamwork and lead to better experience of the users. So DSC is very good intervention where we have all the core measures which we can actually try and implement using the point of care quality improvement. So all 7 core measures: pain, positioning, optimizing nutrition, light and sound management, skin care, family-centered care, and kangaroo mother care. So all the interventions which we can think about DSC, we can use the quality improvement in implementing them. So now neonatal pain, as all of you know, is a very important aspect of neonatal management in NICU. And on an average, a neonate undergoes around 10 to 15 procedures per day, which result in some form of pain, mild, moderate, or severe. We all know that the pain has got long-term hampering effects, and it can alter the baby's response to pain in later life. So if those babies who suffer a lot of pain in the NICU, you will find their response to the pain in the follow-up, like during vaccination and all, is completely different compared to other healthy term babies. The repeated pain results in dampening of the biobehavioral responses. And there are certain acute phenomena of pain, like change in the physiological responses to painful stimuli in the form of tachycardia, fluctuations in the blood pressure, heart rate, intracranial pressure, and saturations. And then during recovery, there is a reperfusion injury and venous congestions, which can result in intraventricular hemorrhage and or periventricular leukomalacia. And friends, untreated pain has the potential to lead to significant neurodevelopmental derangements in the neonate, directly as well as indirectly. And that is why management of pain and stress in NICU is a very, very important DSC intervention. For managing mild to moderate pain, there are non-pharmacologic methods available, which we employ. That is the non-nutritive sucking with or without sucrose, swaddling, kangaroo mother care, massage therapy, facilitated tug, 24% sucrose solution, which was available till last year, but now it's not available. So we are using 25% dextrose in its place. Non-nutritive suck and sucrose or dextrose work by increasing the endogenous endorphins. And it has been found that sucrose or dextrose decreases the crying time and improves pain score after acute mild pain, such as heel stick. And it is also efficacious in reducing the pain from single events such as ROP screening, insertion of gastric tube, heel lance. But we are not sure that repeated dosage, whether it leads to any long-term adverse outcome. And that is why when we undertook sucrose administration for management of mild to moderate pain in our NICU, we decided to stick to 4 common procedures which results in mild to moderate pain in these babies. That is insertion of intravenous cannula, phlebotomy, suctioning, and removal of adhesive tapes. So when you are undertaking any implementation or improvement measure, all those stakeholders involved must understand what exactly we are doing. And that is why the aim statement is a very, very important part of any improvement or implementation. It should be a smart aim statement, meaning it should be specific, it should be measurable, achievable, relevant, and time-bound. The aim statement which we made while administering the sucrose analgesia in the NSU is, we aim to increase the compliance to administration of sucrose analgesia to all eligible newborns. We have to be specific which newborns, which procedures. So undergoing 4 selected procedures in NICU prior to painful procedure from current 0% to more than 80% by 8 weeks. Initial performance was 0 because sucrose was not available previously and we were not using dextrose also. Context plays a very, very important role in implementation and improvement of any intervention. And of course, any healthcare is a team phenomena. So the team is a very, very important core part of the implementation. So our context is that we have a 20-bed level 3 private sector standalone NICU with an average occupancy of 14 and more than 50% babies are VLBW or ALBW, and most of them require respiratory support. So we formed a team consisting of QI expert, that is myself. I was trained in QI in 2016, and this was probably the second or third project we undertook in our NSU. 1 resident doctor, 1 fellow, 4 staff nurses, 1 administrative office staff for supply purposes, and a pharmacist because he has to supply the sucrose. And then we had to assign some roles to the members of the team for clarity and accountability. So the team leader was the senior staff nurse. So leader has to be involved in the care process. Leader must listen to others. Others must listen to the leader. So that person has to, and it should be there at the point of care available. So in this project, so the role of leader, I mean, who should be the leader will differ depending upon the project which we have to undertake. So here we had selected a senior nurse staff as a team leader. The fellow was given the responsibility of literature review and documentation. And we did the root cause analysis. It is a very, very important aspect that we should do the root cause analysis before jumping to solutions. Otherwise, we lose a lot of things, a lot of understanding of the problem. And our root cause analysis, if we don't do, then our solutions will not work. So what we found that there is no policy of administration of sucrose. We don't have that. There is no policy as far as documentation of pain score is in NICU is concerned. We did not have that time. Then there could be place issues like non-availability of sucrose in NICU or at the bedside, no supply by pharmacy. There may be factors related to the people working in the NICU. There is a lack of awareness of pain. They're busy in the work. They don't have the knowledge about management of pain. There may be some process issue, like they don't know how to administer the sucrose. So these were the basic, very, very basic issues in implementing the sucrose analgesia in NICU. And I'm telling you, this is a very, that way, very simple project, but you will understand even a simple project has got so many factors while we try to implement this. So while you undertake any implementation or improvement project in your hospital, you need to modify certain processes or introduce certain processes. So you need to have some measures which will tell you any particular process which we are undertaking, how it is working. So we need to have the process measures. We need to also have the outcome measures. So if any outcome we are going to intend, so that outcome measure, we need to document it, whether these improvement solutions which we are trying to implement whether it is resulting any improvement in the outcomes. But there will be certain issues like vitamin K, where you can have a process measure of administration of vitamin K, but you can't have the outcome measure immediately because it's the manifestations are delayed for 1.5 months, sometimes to 2 months, like a hemorrhagic problems. So in that case situation, we know that vitamin K works, prevents the bleeding manifestations. So we concentrate on improving the process. Similarly, in DSC also, many times we know that DSC interventions work to improve the outcomes, but sometimes it is difficult, many times it's difficult to document the exact outcomes. So we concentrate on process measures. So here we had 3 process measures. The percentage of times the babies receive sucrose analgesia for the given 4 procedures. And so the number of time these 4 procedures are carried out in NICU for each baby divided by the number of time the baby receives the analgesia divided by the number of procedures. And we have to have a data source, which was a bedside sheet or a chart. And then we will also documenting percentage of babies having sucrose availability at bedside. Also, percentage of babies having bedside charts for filling up those. So if you do not document, then it will be difficult to understand what is happening. Here we did not actually targeted any specific outcome measure, but what we can do is a pain score. Although we did document pain score during training purposes, but as a long-term outcome measure, we didn't document that. Then balancing measure also we need to document. So if we try to improve one thing, it should not affect any other outcome or any other process or any other work. So one of the balancing measure here, which we documented, was the percentage of staff expressing concern about work overload. And actually later, when we were implementing our change ideas, one of the balancing measure which we measured was this. And the survey we did from the staff, and they mentioned that 80% of the staff mentioned that yes, the documentation work overload is pretty high. We want to get rid of that. So then we had many change ideas, but we did not directly jump to implementation of those change ideas, how to administer sucrose analgesia. So it is important that we test these change ideas on a smaller number of patients for a smaller number of time. And the reason being, we want to be sure that it works. We want to understand how the stakeholders will respond. It also gives you time to make certain modifications to that particular change idea, because at times we feel this works, but we need to modify it most of the time. We also can understand if are there any unintended consequences arising out of those test idea. So because if we try to implement them directly, it can harm large number of patients. So smaller is better to understand. And then you want to ensure that you have the best possible version of the improvement. Okay, so all these ideas you can get from a small number of patients for a small duration of time to understand all these things. So the first change idea, what was that we tried was training of the staff and doctors, because there was no knowledge regarding this. So one of the reason why sucrose analgesia was not working in our NICU was lack of knowledge. So we carried out the plan, do, study, act cycle. This is called PDSA cycle. So we planned, that the consultant or fellow will train all the staff and doctors to enhance their knowledge about the use of sucrose analgesia. And then we did it. So doctors and staff were trained regarding the use of sucrose dosage by a fellow under the guidance of consultant after the literature review. So during plan phase itself, we wanted to know whether it will be feasible for either a consultant or fellow to do that, whether that will result in change in the knowledge or not. So we did this, and then we studied what we did over a period of 2 weeks. We carried out this training. So during the training, during the study phase, what we learned was staff wanted to know the dosage, but we can't remember. So they wanted the charts in NSU. So we had displayed the charts regarding the dosage because it will vary according to the weight and maturity. And to know the impact of training, we did a pre-test and a post-test. So pre-test before the training and post-test after that. And we documented that the knowledge is increased from 40% to more than 80% regarding the pain and the sucrose administration. And so we adopted this change. But as I told you previously in the beginning, the training alone is not enough. So what we also found it the same thing here. What we did was training, and after that we found that the sucrose administration increased to only about 40%. Okay. So then we try to understand why it hasn't improved to the target of 80%. Then the staff expressed concern regarding the method of sucrose administration. They were not sure how should we administer. They're not comfortable. So then we decided that, okay, we will test different methods of sucrose, and we designated a couple of staffs and doctors to test it on some patients. Okay. And so they did test it using either a sterile gauze or a nipple coated with sucrose solutions. And what we learned from this was the staff was not comfortable with the administration using those two techniques. And because they expressed concern regarding contamination, the nipple may fall down or the gauze may also, they are not comfortable while administering. They were not feeling safe. So what we did was we abandoned those ideas straight away. But one of the staff suggested that we can use pre-filled sucrose syringe and fix it to the warmer for ready use. So that was welcome. And then we asked the same staff to test it on a smaller patient in his next shift. So we use a pre-filled sucrose syringe. We affixed it to the baby warmers, all the babies. And then what he did was he tested it. He tried to administer it using that syringe. And what we found out was this idea worked very well. Staff could administer. But then there was a lot of wastage on some, because some of the babies who were on full feed and stable otherwise did not require any sucrose for analgesia because that baby did not undergo any painful procedure. And of course, the pre-filled syringe had to be discarded after 24 hours. So in the next meeting, this concern was expressed, and therefore we decided to modify this idea with a pre-filled syringe for a baby who's likely to undergo frequent painful procedures, and only fix the vial, unbroken vial, to the warmer of the babies who are stable, who are less likely to require it. So then we decided to test this idea. So we fixed the pre-filled syringes to the sick babies who are likely to undergo many painful procedures in the day, and vials to otherwise stable babies. So we did that, and this resulted in less wastage of sucrose. And this idea then was adapted with a modification that, okay, we'll fix vials to all the babies, but those babies who require it for the first time will open that vial and put it into the pre-filled syringe, and then use it and use that syringe for further management of pain. And then we found that the compliance has improved to around 80% for a few days. But after that, the compliance decreased to less than 80% as bedside sucrose was not available because staff forgot to take the replacement. So this is a photograph showing the pre-filled syringe affixed to a warmer and a sucrose vial affixed to another warmer of a stable baby for ready use. So then this problem of availability of sucrose, we decided to document the bedside availability of sucrose in the staff handover sheet. So because the staff had forgotten to take the replacements and so could not administer sucrose because it was not available at the bedside. So we added one line in the regarding sucrose availability at bed on the nurse's handover sheet, bedside handover sheet. This idea worked well in ensuring the sucrose availability at bedside, and it also improved the administration. So we adopted it. So for some time, the compliance to sucrose administration improved to the target level of 80% or more, but again it dropped to below 80 as the sucrose vials were not available in the hospital pharmacy. And then we asked why it is not available, because the supplier did not have enough stock, as we were the only NSO in the city which were using the sucrose, rather in this region. So not enough sucrose availability was there with the stockist. So what we did was we requested pharmacists to ensure additional stock in the hospital pharmacy by ordering it to the supplier, keeping in mind the average consumption per month. So since this was a special cause variation, because it's not a day-to-day problem, so it might come once, like COVID came and gone. But other problems remain as day-to-day. So those are called common cause variations, and this is a special cause. So we advise pharmacists to keep additional stock considering the monthly needs, and he started keeping it. So we again had a sustained improvement for some time. But one day we saw there is a sudden drop in the administration of sucrose because staff had forgotten to document despite doing administering it. So we decided to introduce bedside checklist for documentation of sucrose administration. So 4 procedures selected were entered into that bedside checklist, and the staff started administering and documenting it. So improved documentation resulted in proper recording of the data, and again we could document the improvement for certain period of time. But after some days, again there was dip in performance to less than 80% because the newly recruited staff did not administer the sucrose analgesia, resulting in poor compliance. So we decided to have a SOP for training the new recruited staff. So SOP was prepared by a fellow under the guidance of consultant, and we decided to have induction training of the new staff. So we carried out that orientation of the new staff, and that resulted in better compliance and sustained use of sucrose for more than 80%. That was our target. We adopted this SOP. But over a period of time, staff expressed concern regarding the documentation work overload. These are all the practical problems you will get whenever you are implementing or improving certain intervention in your unit. So you can't continue to overburden the staff with documentation. So we have to find another way of ensuring the improvement. So we stopped formal documentation. But one day the side effect of it was that during round the clinician noted that some beds do not have the sucrose at the bedside. So what we suggested that during round, let the consultant check the availability of sucrose at the bedside, and if it is not there, remind the staff regarding. So we started consultant check during rounds. And consultant also audited the availability as well as the administration of sucrose. And this idea was adapted with a modification of surprise check during the sustenance phase. So this is the SPC chart, we call it. So these charts will tell you the performance of any intervention which carried out, either it is related to the process or the outcome. So as you can see, we have highlighted on this SPC chart. SPC means statistical process control charts. So these are a very useful chart to monitor the progress of any intervention over a period of time, and you can annotate this chart with the interventions which you have carried out, and the impact of intervention can be easily seen. And if you put these charts in your NIC or at the point of care where people are working in the unit, it acts as a motivating factor also. So it tells them what is the performance after that intervention, and it helps them to take the decisions faster. So I'm not going into details of this chart, but this is how we document the improvement over a time. So on the x-axis, there is a timeline. On the y-axis, there is a performance. So all these process measures and outcome measures you can document on these SPC charts. Because from these charts, you will understand what is happening to performance. You can see the dip in performance in between and where we have tried the different change ideas, the PDSs we have annotated here. And what is the impact of that is in the improvement of the intervention. So in long term, many projects we actually will achieve the success over a short period of time, say a few months or so. But to sustain that intervention over a long period of time, year after year, requires hardwiring the brains of all the stakeholders. By understanding the meaning of sustenance is the new way of working becomes a routine for day to day. Then and then only we consider that we have sustained any intervention. That is also visible if you start, if you continue to document the intervention or the processes or the outcomes which you are undertaking on SPC charts. The only difference between the test phase and the sustenance phase is that the measurement which we were doing almost daily or weekly depending on interventions, here you can document them, say monthly or quarterly based on the measure which you are plotting. So this is showing you the monthly data from October 17 to say December 21. As you can see, there are, it's quite sustained use, but there are certain dips in performance in between for different reasons. So either overcrowding or there was what you can say, COVID effect in January, February 21st, you can see there is a dip in performance. So in order to ensure the sustenance of using sucrose analgesia, we introduced daily team huddles. So we had already actually had huddles since last more than now 4 years. So we included a point of discussion regarding the availability and administration of sucrose in daily team huddle, as there was a tendency to forget, especially when the unit was very busy or during COVID-19, which was a very stressful time for everybody. So we added that point in the discussion phase, and this team huddle actually motivated the staff very much. And it ensured compliance to many processes, including the sucrose administration. So we continue to do our daily team huddles for a short 10-15 minutes, and we discuss any improvement projects. One of the discussion point is any improvement projects or any previous project which are we sustaining or not. Now, all these changes resulted in the sustained use of sucrose analgesia in our unit for last almost 7 years now. So the only change being, since sucrose is not available since last almost 1.5 to 2 years, we are using 25% dextrose. In the initial period of project, it improved from 0% to 96.2%. This was carried out in for 8 weeks from 15 June 2017. And as I told you, that training only resulted in up to 40% administration. But after those iterative PDSA cycles, implementing, trying, testing, modifying, again trying, and then finally implementing the changes resulted in 96% of sucrose administration in those 4 selected processes. So 97.5% for IV cannulation, 94% for endotracheal suctioning, 100% for phlebotomy, and 93.6% for those babies undergoing adhesive removal. So what are the learning? It's a very, very simple and straightforward project. You don't get a so simple project in quality improvement really, but it is good to start with a simple project. So we were also learning it initially. So we undertook this project of sucrose analgesia. Now, over a period of these 6-7 years now, what are the learnings? This is very, very important to understand. Those closest to the work have the best ideas on how to improve it because they own it. That is the frontline staff, the staff at the point of care. The role of leadership is to prioritize the improvement, support it, provide all the resources, and keep the team engaged. So those leaders who are interacting with the frontline staff in a very compassionate manner, in an inclusive manner, without any blame game, those units will have a successful implementation of these improvement interventions. So what are the learnings from this project? Very simple, but a lot of learning. So if we want to introduce or improve any intervention in NSU, be it DSC intervention or any other, we need to have a standard operating procedure documented. How we are going to do it? Any common procedures in your NSU or processes in NSU, you need to have a SOP, how we are going to do it, because every context differs. My NSU context is different than the NSU context of any medical college or any other unit in Delhi, Bangalore, or any other unit somewhere in the tier 2, tier cities of India. So we need to have the SOP, how we are going to work. We need to have training also, regular training protocols in our NSU. Measurement is the foundation of any improvement or implementation. We need to measure the relevant indicators, be it a process or outcome. Some improvement project need some resources in order to sustain the changes, implement and sustain them. Leadership, as I told you, is a very, very important aspect. The leaders have to be very involved. They have to be inclusive and supportive and engage the staff. Psychology plays a big role in implementation and sustenance of all these improvements. Because we have biases, people will resist any change. Years together, they are doing a particular process in a particular fashion. And now suddenly to change that and to hardwire it in their brain becomes very, very difficult. And they will resist changes. Some will resist out of fear. And we need to address those psychological or adaptive barriers to change in order to sustain the improvements. Here, I will tell you one very, very important aspect of any improvement or implementation project is we need to have a person who is trained in that methodology, who has carried out some of the projects in the form of a coach. So we need a QI coach here, even though if it is from the same unit, it is well and good. If not, we can ask somebody to help us. We need a framework. And not everybody in the unit needs to learn the framework in depth. So we need a dosing approach. So first, for the leaders, we need basic training as well as some leadership quality training. For frontliners, maybe we only need to tell them how to do PDSs and how to do root cause analysis. So based on their position, we need to have a dosing approach for learning the framework. And once we achieve improvement, or once we implement any intervention, we need to control and sustain those implementations or improvements by using quality control measures like team huddle or a visual management board, where we display what is happening to our different indicators of the improvement measures we have undertaken. The organizational culture plays a big role in any implementation or improvement, because culture beats strategy for breakfast. If the culture in the system is not good, however you try to implement or improve, it is not going to sustain. So friends, it is not enough to do your best. You must know what to do and then do your best. These are the words of the improvement guru we call W. Edward Deming. Thank you very much.
Excellent QI presentation, sir. Really, the change ideas different what you have narrated, and the sustaining phase was really commendable, sir. Excellent presentation. Both the speakers, participants are really enriched today with your presentations of developmentally supportive care overview from Dr. Sengupta sir and from Dr. Kedar sir. The quality improvement, those NICU who are really who are practicing some of the ideas of developmentally supportive care, how they can make it more qualitative during their day-to-day practice is really well taught, sir, today. Thank you so much for sparing the time for IAP Feed Fellows for sharing your experience and knowledge. Thank you, sir. Thank you so much. Suman ma'am, you want to say something?
think
Sir, we
ma'am
can,
is
yes, ma'am's maybe.
ma'am is
Savita
away.
ma'am,
Yeah.
we can wind up.
Yes, ma'am. Yeah.
Okay. Thank you so much, Dr.
Thank you.
Sengupta sir and Dr. Kedar sir.
Thank you,
Thank
sir.
you.
Thank you, ma'am.
Good night. Good night. Thank you. It was
Right,
great
yeah.
being with you. It was
Yeah.
Thank you,
absolutely.
sir. Sir, you have to
Right.
come to Gujarat for the workshop.
Yes, yes, yes. That we'll definitely.
Thank
Uh,
you, sir.
it will be a pleasure.
Thank
Mid-July.
you, sir.
Thank you. Good night. Good
Thank you
night.
and good
Good
night.
night. Good
Kedar,
night. Good night, sir.
Thank you. Thank you.
Good.